Yes, doctor, you can start.
Okay, sir. So the given topic to me was acute myeloid leukemia. So these they depend upon the recent classification. The AML is divided into six types. Among them, the first one is acute myeloid leukemia with genetic abnormality, that is then MDS related changes, then AML with the therapy related, and AML with the NOAS, and AML with the myeloid sarcoma, and AML with the Down syndrome. So this topic I'm going to discuss only about recurrent genetic abnormalities. So we can go to next one. Yeah. So in 70s and 80s, the diagnosis and classification of acute leukemia was according to FAB classification. The French-American classification was given. So acute lymphoblastic leukemia was divided into L1, L2, and L3, and acute myeloid leukemia was NOS was divided into M1 to M6 stage. And here the requirement to call it as the acute leukemia, the blast should be 30% or more in the blood and also in the bone marrow, except in M6 stage. So in after that, in 2001, WHO classification guidelines was made for acute myeloid leukemia and acute lymphoblastic leukemia. In acute myeloid leukemia, AML with recurrent cytogenetic abnormalities was found out. Among them, there were translocated recurrent genetic abnormalities were identified. Among them, the first one is translocation 821 and translocation 1517, inversion 16, and 11q23. And the second subcategory in acute myeloid leukemia is AML with multilineage dysplasia, AML and MDS therapy related changes in acute myeloid leukemia, and AML NOS. So in this AML NOS, this category will fall into acute myeloid leukemia FAB classification from M1 to M6. So now moving on to the 2016 classification. Next slide, sir. 2016 revised the WHO revised this classification in 2016 of acute myeloid leukemia with recurrent genetic abnormalities. So more genetic abnormalities with fusion genes were found out, so that the patient will have um, correct diagnosis and correct treatment according to the genome which has been replaced. So among them, the first one is AML with translocation 821 with the gene encoding RUNX1 and RUNX1T1. Then AML with inversion 16 or translocation 1616, which is encoding CBFB MYH11. Then acute promyelocytic leukemia with the PML RARA, which is having translocation 1517. Then AML with translocation 911, which encodes MLL-T3 KMT2A rearrangement. Then AML with translocation 69, which encodes DEC NUC214 fusion. Then AML with inversion 3 or translocation 3 and 3, which encoding GATA2 and MECOM rearrangement. Then AML with the megakardioblastic having the translocation of 1 and 22, which encodes RDM15 and MKL1 genome fusion. Next slide. Here, to get to know the patient is having AML, we should go like from history and the lab values, peripheral blood smear blast count, bone marrow aspiration blast count, and bone marrow biopsy to know the stromal and other lineage of dysplasias. And then special stains like iron stain, retic stain, and differential count, and myeloperoxidase, and then flow cytometry and cytogenetics. So these all will play together to get the diagnosis along with the cytogenetic abnormalities uh, to give the treatment and know the prognosis of the patient who has been diagnosed as acute myeloid leukemia. So to know these blasts are really blasts or the blasts are really myeloblasts, we have to go from morphology then to cytogenetics. So next slide. From morphology, so morphologically the blast will be larger in size when compared to the normal lymphocyte. So obviously the larger blast will have irregular nuclear membrane with the 2 to 3 more nucleoli. And the cytoplasm will be basophilic with presence of granules, and few blasts will have absence of granules also. And there may be plus or minus oil rods. So to know this is a lymphoblast or myeloblast, we'll have a special stain that is in cytochemistry. We do as myeloperoxidase staining. So myeloperoxidase staining will be uniformly stained in the cytoplasmic membrane. And if it is uniformly stained and strong diffuse positivity is present in myeloperoxidase, it is called as myeloblast. So we'll know that this is a myeloid lineage. So we'll give it as acute myeloid leukemia. Then coming to immunostains, there is a few immunostains which codes for certain lineage. For example, CD41 will be coding for megakaryocytic lineage like that. CD117, CD15, and CD61 will all code for myeloid lineage. Then coming to flow cytometry, they are uh, blast equivalents, which is a positive for CD117, cytoplasmic MPO, CD41, CD14, and 15 and 13 are myeloid lineage. And according to this, from morphology till till flow cytometry, we'll able to differentiate the lymphoblastic lineage and myeloid lineage. Next slide, sir. So the first genetic abnormality I'm going to discuss is acute myeloid leukemia with the inversion 16. These are the next slide, sir. These are the pictures to find out from the morphological clues which has been present. The first three large cells of blast equivalent, which is present here. You can see the coarse large granules. These granules are often large and purple or violet in color, and it may even obscure the nuclear morphology. So here we can able to see the normal eosinophilic granules in the in C and D picture. So here in acute myeloid leukemia of inversion 16, the patient will have cytogenetic abnormality uh, called presence of Hurleukin cells, which are abnormal eosinophils with a basophilic granules. So the cells, the blast will be more large with the large coarse granules, which is called Hurleukin cells, which have the abnormal eosinophils with the basophilic granules, which obscure the nuclear morphology. So when you see these type of cells, these are the clues, morphological clues that the patient will have some clonal fusion genome, which is present according to the recurrent genetic abnormalities. So it will help aid us to give the patient to flow cytometry and for cytogenetic abnormality, and then we can give the accurate treatment to the patient. So these abnormal granules are most often seen in promyelocytes and myelocyte stages of granulocytic development, and less commonly it is seen in mature eosinophils. So these abnormal eosinophil precursors are almost always present, even when the number of eosinophils are also low. So whenever we see CBC, when there is an increase in eosinophils, we should always think about inversion 16, CBFB, MIH11 translocation. So next slide. Uh, here what? Next slide, sir. So there will be, next slide. There will be coalescing basophilic granules, which is having a large eosinophilic granules. And then the peripheral basophilic granules will be there, and occasional vacuolization will be present in the cytoplasm. And there will be mildly abnormally normal character of eosinophilic precursors will be present. So the increase in eosinophilic maturity with the abnormal character will be present. These are the depicted picture of inversion 16 of acute myeloid leukemia, which encoding CBFB MIH11 translocation. Next, coming to acute myeloid leukemia with translocation 821, which encodes RNX1 and RNX1T1. So next slide. Here, this cytogenetic abnormality which qualifies as AML with a translocation AML. The next one, the next one is irrespective of the blast count, even the blast count is less than 20%, we can call it as acute myeloid leukemia with translocation 821 if the patient is having this translocation of 821. There is no blast criteria for this recurrent genetic abnormality. So in this, few exceptions are this translocation 821, translocation 1517, and inversion 6 inversion 16. So all these three categories, there is no need to have the blast criteria of 20%. It can be less than 20 also. So this is the most commonly encountered AML with a neutrophilic maturation. In this picture, we can able to see there are blast equivalent along with there is a neutrophilic precursor. We can see the nucleus or of irregular nucleus with a trilobed nucleoli. And here, according to FAB classification, it can rarely depict M1 and M4 morphology. And these are the large blast cells with a basophilic cytoplasm, which have many azurophilic granules when we can see in this picture. And these granules will have this perinuclear clearing will be present in the cytoplasm. These blast nuclei are frequently irregular shaped, and this irregular shape, and you can see the long thin oil rods, which can be present as single oil rod or can be as a bunch of oil rods can also be present. And there will be perinuclear clearing will be present. And there is a eosinophilic globules will be present in the cytoplasm. One or two eosinophilic globules will be present. And there is a salmon colored cell basophilic border will be present. As you can see in the right side of the first picture, you can see the salmon colored cell basophilic border and abnormal neutrophils, that is pseudochilia higashi granules will be present. So the below picture is nothing but the bone marrow biopsy, where you can see the paratrabecular infiltration of these marrow blast along with the neutrophilic precursors. Next slide, sir. Next one. So this is the picture depiction of AML with the translocation 821, which is encoding RUNX1 and RUNXT1. Next one, sir. Where you can see the cellular and the nuclear maturity from next one, sir. Yeah. So this is the picture depicted of AML with translocation 821, RUNX1, RUNXT1, where there is no criteria for blast equivalent of like 20%. It can also be less than 20%. And the large blast cell will have long, thin oil rods, and there will be eosinophilic globules in the cytoplasm, and there will be salmon-colored cell basophilic border will be present, and abnormal neutrophils will be present with the large granules, that is nothing but pseudochilia precashi granules. Then we completed our AML with immersion 16, that is the encoding CBFB-MIH11 translocation. Then acute myeloid leukemia with a translocation 821, RUNX1, RUNXT1. So these both categories don't no need of 20% blast criteria. It can be less than 20 also. Next, moving on to acute leukemia with a multilineage dysplasia. Here we can able to see the different levels of erythroid precursors of with irregular nuclear membrane. And the next picture, I mean, in the D and E shows the megakaryocytes with bilobed and hypolobated forms. And the below picture is nothing but the sinusoidal infiltration of the megakaryocytes with a bilobed nucleus. So this multilineage dysplasia will be present as is one of the category previously in 2001. And this multilineage dysplasia is nothing but the patient will be having trilineage pancytopenia will be present. And this multilineage dysplasia will be affecting more commonly in adults. And it has a very poor prognosis, and the patient will have de novo, or if the patient might have already undergone any treatment for any cancer, so this patient will have secondary malignancies. So in multilineage, this AML with multilineage dysplasia can also be encountered in AML with the translocation 69, which is encoding DEC-NEP214. The next slide. So in this translocation of 6,9, which is encoding DEC-NEP214. Next slide, sir. Here, the peripheral in peripheral smear, you can able to see a basophilia. Almost around 44% of the cases have encountered basophilia. So whenever the in peripheral blood, peripheral smear, if you encounter basophilia, think about AML with the translocation 69, the clonal neoplasm encountering DEC-NUP214 with a multilineage dysplasia. In the blast morphology will be the blast oil rods will be present, and cytoplasmic vacuoles will be present, and azurophilic granules will also be present. So in peripheral smear, you can see basophilia with the trilineage pancytopenia, and in blast will have azurophilic granules and cytoplasmic vacuolation along with the oil rods. So AML with translocation 6,9, DEC-NUP214 is commonly encountered in children. and it has a intermediate prognosis. So next, coming to AML with rare cytogenetic abnormalities in AML, there are translocation 6,9, translocation 3 and 3, and translocation 122, and NPM1 mutation. So in that translocation, next slide, sir. Translocation 6,9, I've already explained. And now coming to translocation 122. Um, this is 122 is nothing, acute megakaryoblast leukemia, which encoding translocation of 122 with RBM15 MKL1 mutation. Next slide, sir. So here in peripheral smear, even in bone marrow, you can able to see the blast features as the round, large blast with a round nucleus and 1 to 3 nucleoli, which has a fine reticular chromatin and basophilic cytoplasm with a membrane blobbing or pseudopods in the cytoplasm will be present. And other features clinically, the patient will have anemia and thrombocytopenia, plus or minus bone marrow fibrosis will also be present. In peripheral smear, whenever you encountered anemia with elliptocytosis and the patient is a kid, you always suspect megakardioblastic leukemia. And also in peripheral smear, the blast features will have the specific characteristic of membrane blobbing or pseudopods with the basophilic cytoplasm. So acute megakardioblastic leukemia uh, have a bad prognosis with fusion gene of RBM15 MKL1 mutation. Then moving on to AML with NPM1 and FLT3 mutation. This mutation have AML with the in peripheral smear, you can able to find out this mutation very easily because the blast will have, next slide, sir. The blast will have cup-shaped invagination of the nuclei. So it is very commonly encountered, and the cup-shaped is actually due to the edge of the nucleus, they will have the imagination with accompanying pale area. So the pale area will appear as a nucleolus. That is why the cup-shaped nucleus will be present in NPM1 mutation. So if we do NPM1 staining for this category of AML, uh, the cytoplasm will be staining red colored for NPM and nucleophosphine staining, and we can give it as AML with the NPM1 mutation, and also the cytogenetic studies will be helpful. So next picture is nothing but next step. So here we can able to see the large blast with the auroids also present. I mean, large blast cells of promyelocytes, and in cytoplasm we can able to see more granules we can able to see hypergranular surface in the cytoplasm, and in the C picture we can able to see more number of auroids. First C picture we can able to see one auroid, then we can see bundles of auroids with the slender tapered ends, and the G is showing the vacuolization in the cytoplasm with the neutrophilic precursors. So this is nothing but acute promyelocytic leukemia, which is having a large abnormal promyelocyte with different size and shapes of nuclei, irregular borders and shapes, which is clouded by numerous granules in the cytoplasm. This abnormal promyelocytes can be filled with large, dark, densely packed coarse granules. So these promyelocytes will can have single auroids to multiple auroids, which is also called bundles of auroids with a multiple clumping of chromatin. This acute promyelocytic leukemia will have a translocation of 1517, which encodes PML rara. So this PML rara is like hematological malignancy. As soon as we see in the smear that if the patient is having a PML rara, obviously we have to inform we won't know the cytogenetic, but as soon as we see this hypergranular or microgranular variant, we have to inform the clinicians because the patient will soon get into the therapy of ATROP at ATO. So the patient can be saved from DIC and fibrinolysis because the patient will be presenting with a bleeding, internal bleeding, DIC, and even intracranial bleeding. So quick action should be made according to the morphological clues which is mentioned here. So this acute promyelocytic leukemia will have two flavors, that is hypergranular APL and microgranular APL. This picture, what I have discussed now is the hypergranular variant of acute promyelocytic leukemia. Then coming to microgranular variant of acute promyelocytic leukemia. Here, next slide, sir. The hypogranular variant of next one, sir. Promyelocyte often contains a large amount of cytoplasm, which is the agranular or hypogranular, and this will have a coin-on-coin appearance, like bilobed nucleus will be present, or asymmetric dumbbell-shaped nucleus with irregular nuclear membrane can be present, or it will have a classic blast phase. So the microgranular variant will don't have any large granules on the surface. There is no azurophilic granules, and only with the help of nucleus, bilobed nucleus, we could be able to differentiate microgranular APL. And both the flavors of APL, that is acute promyelocytic leukemia, will stain for diffuse stain positive for myeloperoxidase staining. So the hypogranular APL often has a small population of granular promyelocytes that often contains a oil rod, which is similar to hypergranular APL. So this acute promyelocytic leukemia with translocation 1517 codes for PML RARA. Next slide, sir. So there is a number of visible granules and oil will be present from hypergranular state to microgranular. It will be decreasing in visible granules to oiroids. So, which is more commonly encountered in hypergranular variant than in microgranular variant. So, in hypergranular variant, we can able to see cytoplasmic granules, which can obscure even the nuclear morphology, but and also the ioroids will be there even from single to bundles of ioroids. In microgranular variant, we won't be able to see the cytoplasmic granules, and the nuclear morphology will be differing from coin-on-coin appearance to asymmetric dumbbell shape to classic blast phase. So this is about AML with recurrent genetic abnormalities. Uh, Till now, we have discussed only the translocation related genetic recurrent abnormalities. So whatever the morphological clues we encounter, we have to know it perfectly, and then apply it, and then send the patient blood to the flow cytometry and then to cytogenetics to know the results, so that we will know the patient prognosis and the correct treatment for the correct patient. So we have to multidisciplinary action should be taken along from morphology till the cytogenetics. So I have covered only this much, sir. I hope this is fine. Can you hear?
Yes, doctor. So, yeah, it was good. So, I will forward this to the academic team. So,
Okay, sir.
as soon as I'll just stop the recording.